Welcome to this episode focused on chronic pain, a field where clinical complexity, technology, and patient-centered decision-making constantly intersect. Today, we're delighted to welcome Dr. Reda Tolba, head of the Division of Pain Medicine in the Neurological Institute of Cleveland Clinic, Abu Dhabi. Dr. Tolba brings deep expertise in neuromodulation and advanced pain therapies, with a strong focus on real-world clinical practice. In this conversation, we'll discuss key questions around spinal cord stimulation, when to implement, how to optimize outcomes, how to follow patients long term, how to safely manage them in the perioperative setting while challenging some common myths and dogmas along the way. Let's get started. First question. Dr. Reda, is spinal cord stimulation underused or sometimes is it overused?
Well, spinal cord stimulation, in my opinion, is mostly underused. And the reason is that most parts of the world, if you're talking about globally and we're a global society, there is lack of awareness that this therapy is there. So although there is a lot of patients who might need the therapy, a lot of times they don't have the referral sources because either the physicians or the patient themselves are not aware that this option is there. Other in other places of the world was less fortunate, they cannot really afford to have this available. So if I'm talking about globally, I think it's vastly underused, and there is a lot of patients who suffer from neuropathic pain that can really benefit from this therapy.
Okay. When do you think it's the right time to implement a spinal cord stimulator?
So I think classically in the teaching, it was always said that we have to try and fail everything, and it's a last resort therapy. The
Mm,
problem with that is oftentimes, and that was started back in the early 2000s, those patients keep putting on escalating dose of opioids. And when they come really to have this option, they have other issues such as opioid dependence and hyperalgesia, things that comes with opioid, which make things a little bit the outcomes a little bit less than desirable. So the way I see it, it's not definitely like first line. We have to try medications. In a way, you tried injections, interventions. You have to have a multidisciplinary approach with a psychologist and other places. But more often than not, sometimes those patients are still miserable or they cannot tolerate the side effects of the medications. And we have a classic indications of neuropathic pain, failed back surgery, diabetic neuropathy, who are not or resistant to medications. Further escalating or starting opioids may not be the best answer. And if they
mhm.
failed a couple of injections and they still are suffering and it's affecting the quality of life, I think neuromodulation should be rather in the mind of the physicians to consider to offer this therapy for those patients.
Are we selecting the patients correctly, or are we just selecting indications?
That's a very good question, and this is a clinician, so really it's important to have an individualized approach when you're selecting the patients, and a lot of time it comes with the experience of the clinician. So the clinician should see the patient as an individual, not just an indication. Because a lot of patients I might have, for example, failed back surgery, right? But they're not necessarily having radicular pain. They just had probably surgery should have never been. They don't have the typical shooting pain. So typically speaking, sometimes they have functional back pain. So really, although on paper it's failed back surgery, but it's not really a good on paper it could be a good indication, but when you see the patient, you see some comorbidities, psychological comorbidities and other things, you might think this may not be the best patient. So if
Mhm.
you just go by indication, it might not give the whole picture of a
The best
proper
result.
selection. That's why I
Mm,
think it's very important for those patients who eventually go to this therapy to be followed longitudinally with the physicians, a regular follow-up. And more, you know more about the patients, you know more about catastrophization, other comorbid, other problems, psychiatric problems, just such as anxiety and depression, and you know more. And also, it gives you time to set expectations, which is something that is very important as a
yeah.
clinician to how to set expectation before committing to that therapy.
So, what do you think? Trial first, or you go straight forward to implant? Or are we
So
overvaluing the trial?
No, so I think, in my opinion, trialing is important because it gives first it's there's two different ways of trialing, so European way and the American way. So the
Okay.
American way is percutaneous, less invasive. You leave it for 5 to 7 days, you take it out, and you don't open, you don't make an incision. So it's easy to recruit patients, right?
Mm.
And but it's an extra cost because you have to again, if it's a positive trial, then you have to do the opening and put the two new leads, right? Versus the
Okay.
European way, you open, you put the two leads in, and then you have an extension. And if it's a positive trial, you just put the IPG or the battery in.
Hmm.
But the problem is if it's a negative trial, then you opened, you had an unnecessary cut through the fascia and all this.
Yeah, I
So,
understand.
but I think it gives, although it's not a perfect indicator, and there was a lot of studies talking about trialing and how predictive it is at the long term. But I think, again, it can screen the patient and can detect if you have a drastic response, 90% or more, probably those patients will benefit, although they can have tolerance later on during the therapy, which will
Hmm.
can address other issues. But if they have an equivocal, maybe, maybe not, or then those patients are really, you don't know because technically they could be on the 40, 50%, but they may not do as well when you implant the device over the time. So the short answer is I still think it's warranted for this. It's a very expensive device, as you know. And also
Hmm.
putting that aside, insurance companies, they want to make sure that this expensive device to be reimbursed, it's done to the right patient. So I still think trialing is valuable, but it's not a perfect indicator.
So, considering the technology, do you think that the waveform choice is really important?
So I would like to say that the technology has come a long way since the last I would say 8 years compared to, for example, when I had my fellowship back in 2012, when it was just tonic stimulation and just like a single waveform. It has improved. There's a lot of newer technologies that have waveforms and other programming, and of course this helps and give us versatility regarding giving paresthesia-free or paresthesia-induced options. So it gives us versatility. Having said that, I still think that the most important thing is patient selection. Again, I
Mhm.
repeat it, if you don't select the right patient, whatever fancy waveform you have, you will not have
Good.
successful.
Okay.
So selection and then proper follow-up. How you
Mm.
follow up those patients correctly.
In your opinion, what are the most common technical or strategic implantation mistakes?
So that's important. So the first and foremost for the implanters, they have to really have a rigorous training regarding surgical techniques because putting the leads in the epidural space is one thing. However, keeping them in place, that's the other thing. So proper
Mm.
dissection during surgery, having a clean, you know, proper dissection, proper tissue handling, infection control, again, anchoring the leads in place in the fascia. So you have to expose the fascia really well when you do the incision. You have to have preoperative planning and mark, your point of entry, have a proper MRI, the thoracic and lumbar spine if you're doing a thoracic spinal cord stimulator to expect what you have, make sure there's no severe stenosis on the way of putting the leads, which can cause issues for the patient. Properly do your incision, properly anchor your leads, do your tunneling, do the IPG for example, an area you have to ask the patient before the surgery, where do you want to put the battery in a place that, for example,
Mhm.
if they lie on the right side and you put them on the right side or near where they sit or, against the ribs. So you have to really plan that. You plan it
Yeah.
and put a mark, and you also look at the x-ray, make sure the battery is not rubbing against the ribs if you're doing subcostal or not very close to the bone, sacroiliac joint, for example, because those issues will be there. So you have to really have that proper preparation. And also, when you implant the battery, you want to make sure that also you do a proper surgical technique. When you implant, you don't want to be too superficial, so it doesn't protrude through the skin and causing skin erosion, and not too deep, so you cannot really charge it. So there's a
Mm-hmm.
lot of those things that by experience at doing more, you will have kind of refine your technique. But I
Mm-hmm.
think the most important, the most common complication is lead migration. So proper anchoring, proper placement of the leads, and proper anchoring of the leads in the fascia, that's extremely important. And of course, having a completely sterile technique, proper handling, not be too rough on the tissues, and that comes with experience. And then again, proper IPG placement. And then after that, you want to have a proper follow-up to make sure there is no complications. And if there is a complication, how you catch it quickly and treat it accordingly.
Yeah. So that would be my next question is
Sure.
how is, follow-up is everything. But do you think that this follow-up is being done properly?
Sometimes yes, sometimes no. So, for example, in our institution, we're lucky to have a nurse coordinator, and we have a file of all our patients. We follow them up very closely, and the nurse coordinator job is to track all this patient, make sure they have a phone call after the procedure. They've been followed up on regular intervals to ensure that even if they don't call, they just don't have the implant and disappear. They need to follow up
Mm-hmm.
to make sure that the therapy is going well. They still have good pain relief. And if there is not, then why? And that's extremely important. Unfortunately, sometimes they go to a surgeon and they say they can implant the device. And implanting the device is not, it's just, this is 10-20% of the thing, of the procedure, of the whole management, right? Because you get the most important thing is how you keep those chronic pain patients in control and making sure that it's really effective. So they have to follow up
Mm-hmm.
in regular intervals, even if they don't have any issues. You want to record make sure the device is still working, make sure there's no complication, there's no infection, make sure that the impedance and all the readings are good, programming is good. Does the patient need reprogramming or not? And then if there is lack of response to the therapy after it was working, you want to know if there is any complications such as lead migration, for example, which
Mm-hmm.
sometimes you can lose the coverage. But now with the newer waveforms, you can have a paresthesia-free program. And if you don't have paresthesia and there's a lead migration, you don't know. The only sign that you have is the lack of response to the therapy.
Mm-hmm.
And it could be
Mm-hmm.
tolerance, then you can change the program or do it.
The
But you
program.
have a low threshold to order X-ray for those cases. Make sure the lead although lead migration is less common than it used to be with the new anchoring technique, the lead can still move. And in certain situation when they don't have paresthesia, the only presentation would be that they it's not helping anymore. And then when you do an X-ray, you find it was at T8, now it's down to T12. And then,
Yeah, okay.
so that's back to your question. The follow-up is a key. Having a nurse coordinator or have a team that makes sure those patients are properly followed up and properly serviced is a key to have a
Mm-hmm.
successful neuromodulation program.
Of course. And speaking of failure, so when the spinal cord stimulator fails, how do you see it? Is it a true failure or is just a poor reframing of success?
I think it's important framing. And back to the point that I started early, expectations. So you have to set
Mm,
expectations. So some of those patients, they have some depression, some anxiety, some catastrophization. So those patients, you need to set up expectations for them. You need to remind them how was the pain before. Have some objective measure, so not just BS scores, but pain disability index, other quality measure that you can track and remind the patients of that.
mhm.
And then you have to physically see those patients and know what's going on. And I'm telling you, a lot of times the neuropathic pain is gone, but they complain of SI joint pain, right? This is not going to be helped, or nociceptive pain is not going to be helped with the
Right.
neuromodulation. Then you do a SI joint injection and their pain is gone, the nociceptive pain, and they're happy again. So it's not like
Yeah.
you put the stimulator in and all their pain will be gone.
Exactly.
Yeah. So I
It's
think
like
it's
there's
not
not a magic wand.
exactly. That's why again, consider it as part of the whole, spectrum that you offer to the patient, and make sure you follow up those patients and listen to them.
Okay. So is there something else you want to add, Dr. Heather? We're just ending our
Uh,
podcast.
I think neuromodulation is a very exciting field, and it's it's just the start. And I think with more and more technologies and more awareness, we are hopeful that this will be more accessible to other
Mhm.
countries. I feel a lot of people are undertreated, and the therapy, although it's very well developed at this stage, it's still the access is still not optimal
Limited.
for certain countries. So I hope that in the future we'll have more patients benefiting from this wonderful therapy.
Okay. Well, thank you very much. As we close this conversation, we reminded that advancing chronic pain care is not only about new technologies or devices. It's about thoughtful decisions, multidisciplinary collaboration, and keeping patients at the center of everything we do. As part of the World Day of Regional Anesthesia and Pain Medicine, this podcast reflects a shared global commitment to question dogmas, exchange experience, and continuously improve the way we care for people living with pain. Thank you, Dr. Reda. Thank you for joining us and for being part of a worldwide community working towards better, safer, and more compassionate pain care every day. Thank you very much.